when you think about some of these treatments, it's like you're watching a science fiction episode, right? I mean, so I can take T cells out of a patient, train them how to attack their myeloma, multiply them in the lab, and then give them back to the patient. I mean, if I told you that like 10 years ago, you'd think I was sick, right? I mean, it's just like, it's ridiculous that we could do that. Or that I can give you a drug that hooks onto your myeloma cell, hooks onto a local immune cell, your T cell, and introduces it. And how you doing, right? Like it brings it in, and it brings them together so that it can destroy the myeloma cell. I mean, these are really amazing therapies that have really revolutionized how we're treating myeloma. And I told you earlier, I can't be Joe Prophet, I'm just Dr. Joe. But if I were to predict the future, I am going to predict that these kinds of treatments that we've been hearing about, like CAR T-cell therapy, bispecific therapies, they're really going to change the way we treat myeloma. We might see a lot less of the old school chemotherapy, despite, of course, Manisha appropriately noted that transplant still has a role. So we're very thankful for you, Manisha, for laying that out for us. I know it's a big task I gave you to cover all of that material. And for some of you, some of it was right at the level that you need to understand. Some, you're just getting to understand it. Other people could have given Dr. Bertani's talk here. So we really hope that it benefited you. Now I'm going to ask Dr. Voorhees to make his way up. And I'm going to sit with you here, Pete, on the stage. We have this thing with me and Mike's, man. I'm holding it in the right place. If I stand on one leg, is this good? All right, sweet. So have a seat, Pete. Right. So yeah, that was great. So just as a quick recap, for Empower, we really had three major objectives. And we've been focusing so far on the first two objectives. So objective number one, deep community engagement, right? Doing programs like this, where we partner with anybody and everybody. On the medical side, Atrium and Levine Cancer Institute, the National Medical Association, Black Nurses Association. But then on the non-medical side, we've worked with fraternities, sororities, churches, as you've heard today, hip-hop artists, right? We've worked with just about everybody to raise awareness so people can understand the condition, that if they have the kinds of signs and symptoms that we were discussing before, that they can talk to their doctors about it. If they know someone with myeloma, they can be a support to them. So that was kind of really arm number one of Empower. Arm number two was reaching out to the medical community, starting with the primary care physicians. Let's educate them about the basics of myeloma, how to distinguish myeloma from diabetes, making sure they order the right tests, how to think about myeloma in patients at higher risk, which at the top of that list, of course, are people of African American descent, as we've discussed. And then also to the hem-onc community, as Dr. Tertullian was sharing with us, the importance of having them understand the disease, how them provide the kind of care and use the resources available to them so that patients can have access to treatment. So those have been the two major pillars of the Empower program, community engagement and healthcare provider education. Well, pillar number three, Pete, as you know, which was something you've been thinking and working really hard about, is really to understand the disease even better within the African American community. Because as I showed you earlier, sadly, representation in clinical trials was low. A lot of the studies that have been done that help us understand this disease have been done in individuals that are not Black, individuals that are not Hispanic. And so it's been very difficult to understand really the disease in that realm. We have some work, as we've shared, but we wanted to understand the disease better within the African American community. And this brings me to the question to ask you about the principle of that, and what was the idea around the trial that we're going to talk about in a minute?
Yeah, so one of the things that we were very interested in learning was how our African American patients with multiple myeloma would fare with equal access.
I'm not sure yours is on there.
Care. So I'm having the same
Hold it high up here. So I think when
you need to turn on your mic, Dr. Voorhees.
And is it on? Now it's good.
Are we good?
Yeah.
All right, perfect.
When in doubt, turn it on.
Yes,
Smash.
yes, that works. So one of the things that we were very interested in learning at LCI was how our African American patients with multiple myeloma would fare with equal access to care. We've talked about this disparity in access to care, but if that barrier is lifted, how do our African American patients do relative to patients of other races? So the way that we looked to study that initially, retrospectively, was to look at those individuals that elected to undergo an upfront transplant, both in our African American patients as well as our white patients. And to make a long story short, interestingly, this progression-free survival that Dr. Bhutani was talking about, this initial remission and duration of remission was longer in our African American patients relative to our white patients. So there's actually a signal of improved overall survival as well. Now, we also noted that our African American patients were younger, like Joe has talked about earlier today, and we also noticed that there was a trend towards more favorable disease biology. So there were more of our African American patients who had standard risk or good risk chromosome features of their multiple myeloma relative to their white counterparts. So we did some fancy statistical analyses to account for those differences in age, differences in standard versus high risk, and interestingly, this progression-free survival advantage still remained when we adjusted for age differences, for differences in disease biology and what have you. So what that tells us is that if there is equal access to care, our African American patients are going to do absolutely fantastic. But we did also see some disparities, that are worth mentioning as well. So we were interested in understanding what percentage of our African American patients underwent an autologous stem cell transplant. We wanted to focus on those that were 70 years of age and younger, because most of those individuals will at least be eligible or potentially eligible for a transplant. And close to 50% of our African American patients, 70 years of age and younger, had undergone a frontline autologous stem cell transplant at our institution. And while that means that 50% did not, this number is actually astronomically higher than national averages, so we thought that that was good. Nonetheless, we also did very well with our white patients as well. So 2/3 of our white patients with myeloma underwent an upfront autologous stem cell transplant. So there is still this disparity, and we need to better understand why there's this difference. The other interesting disparity, and this kind of came about when there were some differences in the initial induction therapy that we were giving our patients, so there was less upfront Revlimid use for our African American patients with multiple myeloma, and we were trying to figure out, well, why is that the case? Is it because they're more likely to have their kidney function impacted at initial diagnosis? That wasn't the problem. What we found is that although only 10% of our white patients with multiple myeloma were diagnosed and started treatment in the hospital, 25%, 1 out of every 4 African American patients with a new diagnosis of myeloma, were diagnosed in the hospital and had to start treatment in the hospital. And what that tells you is that they had more advanced disease, they were experiencing complications of their disease to the point where they actually had to be hospitalized to make their diagnosis and start treatment. That's a big problem. I think 10% in the white patients is too high as well. So how can we avoid this problem? How can we reduce the morbidity and hopefully improve long-term outcomes and survival with multiple myeloma? And this is where the idea of screening
So just before you jump into the screen,
Yeah.
though, so let's just focus on that for a second, because we talked about that earlier, didn't we? This notion that the delayed diagnosis means that people are caught later in the disease course. They're more likely to have kidneys involved. They're more likely to have more bones damaged and that sort of thing. And this, you're validating this, sadly, in the work that you're doing. And so a lot of the efforts we have in trying to make that earlier diagnosis is really important. I don't think we can overemphasize that. The whole field of myeloma is starting to appreciate that, even though Dr. Bhutani shared with us those amazing things that we're doing with CAR T-cell therapy and bispecifics, what very often makes the biggest impact in a myeloma patient's life is what they get early on, how they do well, because that first remission is the longest remission. And so focusing efforts on that front line, I think, is really important. And I really appreciate that you have one of the largest databases in the country of patients of varied races and backgrounds to be able to evaluate that. So we appreciate that you've been doing it. And it really sort of re-emphasizes the importance of what we're doing. I tell you, for example, one project we're doing with our colleagues at Grady Hospital in Atlanta is to try and speed this diagnosis up. Part of the problem, we think, is that the family doctors and the primary care doctors don't know which blood tests to order, because ordering myeloma blood tests is not simple, as some of you have come to learn. And so if they miss one of the key tests, they may miss myeloma. So we've created what I call the easy button. In their healthcare record, something called EPIC, which I know for some people is like a 4-letter word, but the EPIC system, which can be challenging at times, they just have, instead of saying, I need to order test 1, 2, and 3, they just say, does the patient have myeloma? And all 3 tests get automatically ordered. And I think that kind of process, is the sort of thing that'll help. But I could have interrupted you there because I just want to emphasize your point. But that led to, I know time's going quickly, but to your plan of a screening study. Maybe you can tell us a bit about the screening study.
Yeah, so this is a study that's being spearheaded by Dr. Bhutani here at Levine Cancer Institute. So it's called CHAMP, or Charlotte African American MGUS Project. Remember, MGUS is the precursor to multiple myeloma, and everybody with multiple myeloma invariably goes through an MGUS stage before they're diagnosed with active multiple myeloma. There have been very elegant studies done to support that. So the question that we have, if we diagnose, people at their MGUS stage, their precursor myeloma stage, and get them access to appropriate health care, can we reduce morbidity when some of those patients ultimately go on to active multiple myeloma, and can we improve survival? So what we're proposing to do in the greater Charlotte community, and we would love all of your feedback, feel free to talk to me, after the sessions and what have you, but we would love to have you guys actively engaged and, raise awareness of what we're trying to do. But we're essentially going to approach the African American community in the greater Charlotte area, anyone 30 years of age and older, and invite them to be screened for multiple myeloma. It's a blood test, just like Joe said. So you have a vial of blood drawn, it gets sent to the lab, and we test you for MGUS, for precursor myeloma. And if we identify it, then we get you access to appropriate health care, whether that's through your primary care physician with guidance from us about what to do, whether it's through Dr. Thurtulian at Novant, whether it's through us at Levine Cancer Institute, but we get those people access to care. And to Joe's point, a lot of people with MGUS are not going to go on to develop active multiple myeloma, but there are going to be some of those that do, and we want to identify those that do. And the nice thing about this in the long term is that we'll be collecting samples over time, and we can look at, those patients with MGUS who go on to active myeloma versus those who do not, and then go back to this treasure trove of samples and go, are there any markers that we can identify that would have predicted that, patient A was going to go on to active myeloma versus patient B, just sitting at MGUS for the rest of their life? So there's a whole wealth of things that we can do, with this data in the years to come. But again, very much interested in hearing people's feedback about this.
And as we roll it out, of course, as it gets rolled out, we'll definitely inform everybody. But, well, thanks, Pete. I mean, that's such a great, this is really the history of research. We need to understand a disease before we can treat it at its best, and trying to understand it better with so much work. We've had the privilege at the IMF of being a part of the largest myeloma screening study in history. We've screened almost the whole country of Iceland, and it's amazing how much we're learning from it. But with all due respect to Iceland, it's not the most diverse place on the planet, right? I'm just being honest, right? And that's okay. It was the right place to do the study because there are certain things that we wanted to learn and understand. But someone could be sitting here saying, I don't look like I come from Iceland, so how does this apply to me? And so that's what's, I think, so important about the study. And Pete, thank you so much for your time, your effort, your dedication, and leading this team and this group in the area. And I look forward to having you back on stage in a few minutes for our Q&A. So thank you.
Absolutely. Thank you.